So something about me, I'm an infectious disease doctor, internal medicine, but I'm working as from the Department of Virology. I'm a professor in clinical virology. And here you see some pictures of my research group. So many of them, or most of them, are clinical doctors who start a PhD in virology. And we do work in a translational way. That means that we are clinicians, but we bring questions from the clinic to the laboratory, and also abilities and results from the laboratory we try to bring back into clinical practice. Working in the field of emerging viral infections, well, that brings us on several places all over the world. You see some pictures in the Erasmus Medical Center, but also the one at the left, bottom left, one in Indonesia, Surabaya, where we work together with the Indonesian colleagues and visit the patients. And the one at the right bottom is in Suriname, at the academic hospital in Paramaribo, where we also visit the patients. And this is a picture during the Zika outbreak in South America that started in 2016. So that's something about our group. Well, if you talk about emerging infectious diseases and the topic of exotic virus infections, so exotic, we mean that these are those infections that are mainly endemic or epidemic in tropical and subtropical countries. Then in the recent past, we talked about exotic viruses as import infections. So they were not endemic, not circulating in our regions. Patients we do see here with exotic virus infections, they have been on vacation, on holiday, or on a business trip, and they come back and develop complaints. That's what we call an import infection. But what we see, and that's development over the past, well, 20 years, and that really is going very fast, is that we see that new exotic infections are introduced in Europe. It started in the south, in the middle of Europe, and also the northern European countries, also Netherlands. More and more exotic infections are introduced also in our region. And that means that we have to count with the possibility of patients infected here that were not traveling. And we even have to prepare ourselves for future outbreaks. And we will come back to that later. Well, an important thing in infectious disease, and that's what we also see in COVID, is communication, science and public communication. How do we inform our public that they are aware of what's going on, to motivate them also to take predictive measurements, hygiene measurements. And I think the corona outbreak very much shows us how important this is. And we must be very, as professionals, we must be very much aware of this. Well, if public communication is not going that well, or if it has been started too late, something that you see on this picture can happen. And this is a picture from 2014. It's very recent, and this is during the Ebola outbreak in the United States. And what you see on this picture is that there is an absolute panic under the general public, and people, well, they were very afraid, and there was a call for measurements that were not very realistic. So to close the borders for all Africans and all African countries, that was not very realistic, and it was not very efficient. But you see what can happen in a, let's say, modern country at these times when public communication is not started at the right times. So this is all to do with awareness. Well, I brought some patients this morning, just as examples for emerging virus infections. I will ask some questions, and you may contribute to the discussion. I will ask you to give some suggestions. This is a young student. She went to Suriname, and she went there for study, and she stayed there for a 3-month period. And 4 weeks before she returned, she suffered from fever with skin rash and joint pain. And she very much complained about the joint pain, but the fever recovered, but the joint pain didn't resolve. And when she came back to the Netherlands, she still suffered from joint pain. Her history, medical history told that or travel history told that she has been in Indonesia and Senegal before, and her vaccination history told that tells us that she has been vaccinated according to the guidelines. So, is there someone who could give a suggestion what these young students, what kind of infection she could have been suffering from? At the time she had fever and she still has complaints. Is there someone with an idea?
Could be lupus.
Sorry?
It could be lupus.
Lupus?
Yeah.
Okay, so that's a systemic infection, autoimmune, you mean?
Sorry?
You mean an autoimmune disease?
Could be.
Lupus. Are there other suggestions? Of course, you need something to know what kind of infections are present, are circulating in Suriname. Someone?
In the chat, there are some suggestions.
Oh, wait. Let's see if I can go to them. I have to find the chat.
Shall I call it? Shall I shout, Erik?
Yeah, please.
So there's malaria, there's dengue, there's chikungunya, there's Zika.
Okay. Well, that sounds very very good. I am happy with that. So that shows that you are familiar with epidemiology. You know what kind of infections are circulating, and these are all possibilities. So differential diagnosis tells us something about the probability of diseases. Of course, malaria should be one if you return from the tropics. This girl didn't have fever when she returned to the Netherlands, but at the stage when she presented in Suriname, it could have been malaria. Although malaria is not very present in Suriname, it's still possible, so it's very good. Yellow fever is a possibility. There has been a large outbreak in Brazil, so the neighbor country. She had been vaccinated, so the chance for yellow fever is very low. But it's good to put it in your mention it in your differential diagnosis. Dengue, indeed, dengue is an endemic infection in Suriname, and during the rainy season, every year we see more cases, and it has an epidemic pattern, so with peak incidences. Chikungunya, indeed, and if you look to the clinical picture, also Zika is a possibility, and dengue, chikungunya, and Zika are infections. If you look to the clinical pattern, that patients suffer from joint pain. So this could really, this is a good differential diagnosis. Another infection, if you have fever with unknown origin, also to put an STD, so sexual transmitted disease, in your differential diagnosis, and don't forget about HIV. That should be on the list, especially when you don't find another diagnosis. Okay, something short about diagnostics. The time when she presented in Suriname, we could have done a PCR. So with that test, we can really detect the virus. But at this stage, when she returned in the Netherlands, it was already some weeks later. So the PCR will be positive for around 5 days, max 7. So weeks after you don't do a PCR, that will be negative. So that doesn't tell you anything. But then you will count on serology. So look to antibodies. And the message I want to give here, if you look to antibodies, that sounds very easy. You just ask for antibodies, for instance, for dengue, chikungunya, or Zika. But there is a big thing with the serology, and that is cross-reactivity. Viruses belong to certain groups, and there may be cross-reactivity. So that means that if you have seen another infection like Zika in the past and you get a dengue now, it might be that you see an antibody response, but it's not specific then for dengue, but it may be a response to a former infection like Zika. And that is what we call cross-reactivity. And that means that serology is not very specific. So with the PCR, we can make a certain diagnosis, and with serology, we have to take into account that it is not very specific, especially when people have traveled a lot to the tropics or are living there and living in an area where these kind of infections are endemic. So that has something to do with the diagnostics. Well, much of the emerging infections, many of them are neglected diseases, and that means that there's also a list that's used by the WHO, that are those infections that has a potential to become problematic and to cause epidemics or even pandemics. And there's a long list. Those neglected diseases don't get the attention that they should deserve. So there's not enough money, not enough attention to do research on these infections. I come back to that later. Well, it is good to realize that if you look to the zoonotic infections, can someone tell me what the zoonotic infection is? Do you know that term? Jan, ik zit even te kijken waar de chat zit bij Zoom. Zit hij in het bovenste
Onderin heb je die balk waar je share screen kan doen.
Oh, zit hij daarin?
En dan staat hij links van share screen zit chat. Kan ik vinden of niet?
Ja, participants. Okay. Well, the term zoonotic means these are those infections with an animal as a reservoir. And what you see is that most emerging pathogens are zoonotic, and that means that there's an animal reservoir, and transmission to humans depends on behavior, how we interact with those animals. That can be a direct interaction with the animal, and it might be that there is a factor needed for transmission from the animal to humans. That might be a mosquito, for instance. So, but remember, most of the emerging infections, even 75% are zoonotic infections, and much has to do with our behavior. Well, this is a list that the WHO uses. It's a list with the 10 threats to global health in 2019. It's not only infectious disease, and we will look to that. What are the 10 threats mentioned by the WHO? That is air pollution, climate change, non-communicable diseases like hypertension, diabetes, also cancer. Those diseases are on the increase also in the tropical and subtropical countries. A global influenza pandemic. We do have corona at this time, but if we look to history, every 40, 50 years, we see a pandemic with influenza. So we still count with the possibility at these times. Fragile and vulnerable settings. So not very strong healthcare settings. If there is a problem like an epidemic or even pandemic, those settings will not be ready to cope with this with such an epidemic. Antimicrobial resistance, that's a really big issue worldwide and listed in the top 10 list. Also in the Netherlands, there's much attention on this topic. Ebola and other high threat pathogens. We have seen the outbreak from Ebola in 2014, but there has been a new outbreak between 2017 and the beginning of 2020. So that took 3 years in Congo. And we have seen the impact in 2014 from the outbreak. Weak primary healthcare systems, vaccine hesitancy. So for most of the infections we are confronted with, we don't have vaccines. It takes time, it takes money, time, and sometimes it takes, well, much time. Take into account HIV. We know that infection for about 40 years and we still do not have an effective vaccine. So sometimes it's very easy and sometimes it's hard to develop an effective vaccine for an infection. But at the other time, for many infections, we do have effective vaccines, for instance, for measles. And then we see that people not aware about the infection they are prevented by the vaccine, they think, well, I think it's not very worthwhile to take that vaccine. Maybe there are side effects. And that much has to do with awareness. And well, what we see is that the coverage of the vaccination programs is decreasing. And that's really worrisome because then the protection, not only from individuals, but also from the population on a whole is at risk. And infections like measles are on the increase also in Europe, especially some Southern European countries, but also in the Netherlands, it's a critical point. Well, dengue, mosquito-borne infection, not a new one, but it's still very present. And HIV, take into account that HIV still is pandemic. It's spread over the continents. It's still not under control, and even in the Netherlands, we do see around 800 new patients every year. So we could not stop it till now. So that is still a pandemic infection. Well, this list, out of this list, WHO made a blueprint, and you only can read the lower section in yellow, and you see that the WHO mentioned some infections with very exotic names like Crimean Congo hemorrhagic fever, Ebola, Marburg, and several others. And those are infections listed at the priority list because they are mentioned as the infections that are very realistic to cause problems with outbreaks. And at the end, there is a disease X because we can predict and prepare for many infections. And it might well be that we are confronted with a totally new infection. It might be a new one or an old one that is reintroduced, but an infection that we did not count with till that time. And that's disease X. Corona also is such an example. We counted with the influenza pandemic, but it was not influenza, it became a corona infection, COVID-19. So that was the disease X of this year. And here you see the example for corona, COVID. Well, it all starts with awareness. That's awareness for us as clinical doctors, people working in primary health care, but also public awareness. If there's no awareness, there will be no action. It cannot lead to preparedness, and in the end to prevention or treatment if necessary. So awareness, and that much has to do with communication, is very crucial. Well, this picture I show you just to show you that if you look to emerging infections, that you see that they can pop up everywhere. It's not only in Africa or South America or in countries with a poor healthcare system, but also in the Western European countries, and even in the Netherlands, we can have outbreaks with new infections. For instance, for the Netherlands, take into account the Q fever outbreak, very recent. That was a large outbreak. So also in the Netherlands, we may be confronted with the start of an outbreak that can become epidemic and even pandemic. So the potential is there. So we must be aware of that. Well, the factors contributing to the spread of infections all has to do with behavior that we can say in advance. Factors that contribute is that we are met with much more people. So the world population is increasing, and most of the people are living in urban settings. So transmission is facilitated in that way. This is a picture just showing, and this is for the United States, how many people are crossing the border on a daily basis. But you only also see how many animals are transported. And the same picture you can make for Europe and other continents. And we already learned that a majority of the new infections, the outbreak infections, they are zoonotic, so they have to do with animals and people. And we are transporting both animals and people on a large scale over the continent, over the world. So that's a risk factor. Well, climate change, maybe 10 years ago there was discussion, is there climate change? But I think we are all much aware that there is climate change. And in this picture you see, and this is the measures that already a very small change in the average temperature, and that may be 2-3 degrees on an average base, can already have an impact on infectious diseases. And that in the context of, for instance, mosquitoes. Mosquitoes are introduced also in the Netherlands. If we have a real winter, the winters are too cold for the mosquitoes to survive. But if the winters are more mild and the average temperature is increased some degrees, those mosquito populations can survive and they may become permanent. And that's the start of the possibility that exotic infections may become endemic, and endemic means that they are circulating in our region. They may become endemic, and then we can expect that we will see patients. Another thing that has to do with climate is water, because water is very important also in the context of mosquito-borne infections. Mosquitoes do need water to breathe, and more water reservoir containment reserves also facilitate the spread of mosquitoes. And these are just some examples. So climate change has a major impact on the spread in the epidemiology of infectious diseases. Well, this looks like a picture from the far past. But if we look on a worldwide scale, then the majority of the world population is living under circumstances like here. And I put this picture to show you that you see all transmission possibilities for infectious diseases are, you can see in this picture. People are living very close together. So airborne infections you can transmit very easily. You see the water. Mosquitoes use water to breathe, and in this area you will have large mosquito populations. The water is not clean, so if you use this water for food preparation, water and foodborne infections will be present here and outbreaks will occur. You see the carpets on the left down picture, and the carpets, there will be rodents, and rodents are very prominent in transmission of infectious diseases. People are living very close to their animals, and that's the picture in the middle. And we learned about zoonotic infections, and people do not live, they're very much economically dependent on living with these animals. Well, to take it in summary, we see all transmission routes in these kind of areas, and realize that a large part of the world population is still living under this kind of circumstances. Well, this is a picture I made when I traveled in Indonesia, and there was heavy rainfall, and that's not very uncommon. Tropical rain showers. This village, you see that it's flooded. On the boys at the right side, you see, I think you agree on that, well, they seem to be familiar with this. It's not uncommon. If this would happen in Rotterdam, the picture would show different people with different faces, but they make the best out of this. But the thing is that if something like this happens, that after this flooding, you will see outbreaks with water and foodborne infections, rodent-borne infections, but in particular also mosquito-borne infections, and that's what's happening all the time. So that has to do with environment, that has to do with climate change, it has to do with behavior also. So this is just an example. And this is what we just discussed, the transmission risk. These are the main transmission routes for infectious diseases. So food and waterborne, mosquito and rodent-borne, blood-borne, airborne. and the sexual transmitted diseases. And mosquito and rodent-borne are put in yellow because if you look to the exotic infections, the mosquito and rodent-borne infections are the main transmission routes. And what I already said, they are becoming more realistic also for our regions because mosquitoes are introduced, and also rodent populations, although in the Western countries and especially in the urban cities, also in the Netherlands, we do see more rodents, rats living between houses with the people. So we must take into account the risk for rodent-borne infections, also in the Western countries. Well, just some examples: mosquitoes, rodents, and also the vleermuis is one of the. It can be a reservoir, but also a factor in transmitting the bats. They can be a reservoir, but also a factor in transmitting infectious diseases. We come back with an example later. Well, you realize that often I speak about mosquito-borne infections. They are very well prominent, and they form a risk worldwide and also for our region. And we summarize them under the group of the arbovirus viruses. Many of the new infections, they are not solely virus infections. They may also be bacteria. But if you look to the outbreak infections and new infections, most of them are viruses, and that's why we are concentrating on viruses in this lecture. And then the arboviruses are a special group. Well, what's the definition of an arbovirus infection? That are arthropod-borne viruses. They are transmitted by mosquitoes, ticks, for instance. Well, I could ask you which arbovirus infections you know. Due to time, I will continue because you already mentioned some in the first patient case that we discussed: dengue, chikungunya, Zika, West Nile virus, yellow fever, gele koorts, tick-borne encephalitis, Japanese encephalitis, all very exotic names. Of Sutu virus came in Congo. They are all transmitted by mosquitoes. And well, this is an important question, and maybe one of you can tell me, do you know for which of these infections we do have vaccines? Because the question is, for how many infections can we vaccinate? Who knows for which infections do we have vaccines available? Can you mention one or two?
For yellow fever, right?
Yeah, yellow fever, that's a very good. So yellow fever is belongs also to the hemorrhagic viruses. It can cause hemorrhage, and we do have a very good vaccine for that. Yeah, that's right, yellow fever. Others? Well, we do have one for yellow fever. You see it here. We do have one for Japanese encephalitis, and we do have one for tick-borne encephalitis. These are all safe and very effective vaccines. We have one for dengue, but it's not very effective, and that's why it's not listed here. But the message is that for most infections, we still, at this time, we do not have vaccines. And if there is an outbreak, the response waiting for a vaccine is not very realistic. We see that with Corona. It takes a lot of money, it takes time, a lot of efforts to develop that vaccine. So the first response should not be waiting for the vaccine, but change our behavior and block the transmission route. Well, looking to the arbovirus infections, those transmitted by mosquitoes or ticks, that is about the transmission route. So you can group viruses like that. And well, these are the arbovirus infections. As clinical doctors, it's also very relevant to be aware what kind of patients can I see in my clinic, in my hospital, and what kind of symptoms they will have. If you look to the arbovirus infections, you can discriminate two important clinical pictures. And one is the group of infections that cause encephalitis. So that's to say brain tissue infection. So that's different with meningitis. Sometimes it's a mixed picture, and meningitis and encephalitis. So that's a large group with very exotic names. And the other group are the viral hemorrhagic fevers like dengue, yellow fever, Crimean Congo hemorrhagic fever. So this is a way to list those infections. You can list them on transmission routes. You can list them on a clinical picture. Well, it depends on how you are working as a clinical doctor. You want to see what patients can I see in my clinic. If you're an epidemiologist or working in primary healthcare, then you are busy with transmission and blocking transmission routes. And then transmission routes is the main is the main grouping of viruses that's relevant for you. So mosquitoes, they're in the news. You can open the newspaper and then, well, at regular times you find messages that exotic mosquitoes are found in the Netherlands. In the Netherlands, the Voedsel- en Warenautoriteit, you see it here in the upper block, the NVWA, is going to see to the places where mosquitoes are found. And they are going to see what kind of mosquitoes that are, if these mosquitoes are spread, and if there are environmental risks for these mosquitoes to spread. At this time, those mosquitoes are imported by tires. There's a large tire, from automobiles, so car tires that are distributed over the world, that they are traded. But in that tires, there's a small piece of water. There are mosquito larvae, and they are introduced and imported in countries where those mosquitoes are not present. And the other way for these mosquitoes to be introduced is the import of lucky bamboo from China. And in the Netherlands, these are the main routes of introductions for these mosquitoes at this time. So you see that they are in the list. These are small messages, and this is what we see the past 10 years. And still the average temperature is a bit too low for these mosquitoes to become a permanent population, but that's changing. Well,
Sorry,
yeah, sorry.
have there already been cases of dengue then in the Netherlands because of the mosquito traveling to the
Okay, I come back to that later. Last week, there was a message. There was a traveler from the Netherlands to France. He has been infected in France. So there has not been transmission yet in the Netherlands. So that means the mosquito, I come back to that later. The mosquito is here on a temporary base. The virus is not circulating yet. So there's not been transmission yet in the Netherlands, but in the south of Europe, it has been, or it is happening. And last week there was a message from a case, a Dutch traveler infected in France with dengue. Well, this was last week. Maybe you followed the news, or maybe it could be that you missed, but the West Nile virus is found in the Netherlands. So there are bird ringers, so the vogelringers, they are volunteers, they do surveillance among birds, and they found a gasmus, and they took samples. They were sent to Erasmus, to virology, and for the first time, West Nile virus was found in the Netherlands. Has that any importance? Has that any impact? Well, this is still a report. On the left upper side, you see that the gasmus was found, how the virus was detected. At the same time, entomologists from Wageningen University, so entomologists, those people involved in mosquito research and surveillance, they found that mosquito pools in the Netherlands were also carrying this virus. So that means the virus is there. There are mosquitoes that are infected with the virus. So it seems that it is a matter of time that we also will see patients with West Nile virus. And that is really, well, for if you look 10, 20 years ago, that was an exotic infections. On the third picture, we see that it has something to do with temperature. And this is a picture from the KNMI. And what they showed over the past period, that the average temperature is rising. But if we especially look at this summer, it's not only the average temperature, but also the night temperature is. So what we see is that at night temperature does not fall like we were common, but night temperature seems to stay very high. And this might be a crucial factor in the spread of these infections. Well, this is the transmission route. So West Nile has the birds are the reservoir. Birds even can get sick, and they may even die from the virus. And the virus can be transmitted to humans and horses, not directly. A mosquito is in between, so that's the vector. So you have the reservoir, the vector, and then the host, and that can be humans or horses. We call that a dead-end host because there's no human-to-human transmission, and that has to do that the virus titers that I found in humans are very low. So mosquitoes are not able to pick up the virus from one human and bring it to another, just because virus titers are too low. So then we talk about dead-end hosts. But this is the transmission route for cycle for West Nile virus. What is West Nile virus? Well, it's causing encephalitis. For many infections, we also have seen that in corona, we use the pyramid. And we see that, well, most people will not be aware if they are sticking by a mosquito. They may be infected, but their immune response will be adequate. They will not get sick. They are asymptomatic. 20% will develop a mild disease with fever. And then there's a small group, relative small group, to 10% who they are coming to the hospital and they develop a severe encephalitis. And in this group, there's also mortality. And you see that it is mainly the elderly, again, people with an immune response that's not adequate anymore. They are sensitive or vulnerable to develop severe disease. So that's about West Nile. So that's a very relevant disease, and that means that we as clinical doctors, if we do now, today we will have a patient with encephalitis, we test them for the common causes like herpes virus, and there are some others, tick-borne encephalitis is one, but also West Nile should be on the list, and it might be that you are the first doctor detecting a clinical case with West Nile fever in the Netherlands. Well, this is looking back to the recent past, and that was 1999. There was no West Nile in the United States, but then in 1999, you see it at the right, you see some red spots and blue spots. And there were cases for West Nile virus, the blue case, the blue spots, these were cases among horses, and some red spots, these were cases, some human cases. And then we see what happened. This is 1 year later. There was a spread among horses, some more human cases already, 2001, 2002, 2004, 2005. And we are much aware that this can happen with Europe. And actually, it's already happening. So West Nile is spreading from the south to the middle to the northern European countries. So this is the past. West Nile was not, it was already detected, individual cases in Middle Europe and Eastern Europe countries, small outbreaks, but till recent the virus was not able to spread on a large scale. So outbreaks were very limited, and there were only a few cases, and the virus was not spread to Middle and Northern European countries. So that has been changed. That has been changed. Well, this I want to show you, because if you look to the mosquito-borne infections, how can we predict for the future? And what we see on the in the upper line of this schedule, we see the mosquitoes, and on the left we see the different viruses. And here we know, well, certain mosquitoes are able to transmit certain viruses. So that means that if you know which mosquitoes are circulating in your environment, in your country, you can make a prediction what kind of viruses can be introduced, and even clinical cases you might see in the future. So this is part of surveillance, and entomologists, so people working with vectors, with mosquitoes, it's their work. They place traps all over the country, and they find these kind of mosquitoes, and based on that information we make predictions, and we know for which kinds of infections we must be aware. This is a picture with the same here, the mosquitoes, and here we do see the different countries, European countries, and then we see that which mosquito populations are circulating in the different countries. And this is in the middle is the Aedes albopictus, and that for Europe, this one is very relevant. It's circulating all over Europe, and it can transmit many viruses. So for Europe, this is the most relevant at this time. And that's what we see here. So we have different mosquito populations. At green, it means that the population has not been found yet. So this is the Aedes aegypti. In yellow means that it has been introduced, and red, it means that it are permanent populations, so present there all over the year. So for Aedes aegypti, that's not the case yet, although in the Netherlands you see that there is a small yellow line here. So that means that Aedes aegypti is introduced in the Netherlands, and that's due to import, as I mentioned before. So tires and also lucky bamboo from China. This is the Aedes albopictus. I already told you this is the most relevant one for Europe. And this is a different picture because you see the yellow areas. It has been introduced, not permanent, in large parts of Europe. And the red areas, Aedes albopictus, is a permanent population. So that's in the south, and it's coming up to the middle. And we are very much aware that this it will not last long before these populations will also be permanent even in the Netherlands. Well, this is another mosquito population, the Aedes japonicus, and we see a similar picture, but at a lesser extent compared to the Aedes albopictus. Well, I brought a patient. This was a young lady. Again, she went to Suriname. Don't be afraid to go to Suriname, because I brought some patients from Suriname with all kinds of infections. But she gets awake in the morning. She was there for study, and she went to the rainforest. That's very beautiful in Suriname. And she was sleeping under a bed net, and well, she took all kinds of protections, but in the morning she got awake, and this was what she saw. It was not painful. She had not been aware. Someone has, oh, there it, a little bit. Someone has a suggestion what could have been happening here? Any idea? Well, what happened here is that the girl has been bitten by bats, vampire bats. They have very small teeth, and they are damaging the very small vessels. The vessels. It's not painful. If she's washing her feet, you will not see anything. So it are very small wounds. And the risk she has is for rabies, hondsdolheid. So the main question now is she vaccinated? If you travel to the tropics and subtropics, then for many countries there's an advice to take the rabies vaccine. if something happens like this, if you are in contact with bats, but also with other animals like dogs, street dogs, or wild animals, then there is a risk for rabies transmission. If you are vaccinated, hopefully you're at the safe side. If not, this is a very serious infection. Worldwide, there's an estimate that around 50,000 people on a yearly basis die due to rabies, Hondsdolheid. It can cause encephalitis. And what we know, as soon as you are developing symptoms, the mortality is 100%. So it's a very serious infection. We do have a vaccine for it. It's very effective. And if you're traveling, and especially when there's a risk that you are going to areas and also coming into contact with animals like bats or wild animal or street dogs, then there's a strong advice to take the vaccine. If you're not vaccinated, and because the outcome is maybe that worse, you will get passive immunization, and that means that you are getting antibodies, and that can protect you. That sounds very easy, but those antibodies are not present. If this happens, so a traveler is coming back to the Netherlands, there's one site at the RIVM where we have those antibodies, and we can order them and give them. But if you're somewhere in a rural area, in a place in Africa or South America, it may be that maybe very well be that those antibodies are not present, that people are not aware that those antibodies should be administered. And then in those cases, it might be that people develop rabies. In the Netherlands, it happens once, well, a year, 2 years, that we see a patient with rabies encephalitis in the Netherlands. And those people certainly die because there's no treatment, and mortality, as I said, is, well, 100%. Well, if you look to the emerging infections, and I already mentioned a bit about that, it would be nice if for all those infections, okay, maybe we cannot prevent, but if you come to the hospital, we can treat them. But be aware that for most of the virus infection, the emerging virus, we don't have a treatment. So antiviral treatment of these infections is an open area, because for most infections, there is no specific treatment. Supportive treatment is very important. That means keeping an adequate fluid balance, saturation is important, and supportive treatment, but there's no specific treatment. I already mentioned that for most infections, we don't have vaccines. We have a lot of vaccines, but for the majority of infections, we don't have. So vaccination, as I said before, is not an adequate response, first response in combating an outbreak. And that means that prevention, and that has to do with public awareness, is the crucial thing that we should do. So talking about that, vaccines, who knows what is the average time to develop a vaccine and bring it to the market? Much is to do about Corona, so I think you have an idea about that. Can someone respond on that? What do you think? There's no good or wrong, but someone?
10 years.
10 years? Is someone saying, well, this is very optimistic, it's much longer? Or maybe another one says, well, this is very pessimistic, that can be much faster. Someone? Okay, maybe a difficult question. Well, the question is not difficult, but maybe the answer. And that's true. And that has to do with this. This picture shows drug development, and the same is for vaccine development. So at the left side, you see, if you start with basic research, you have an idea how a vaccine could work. You start at the laboratory, you work with cells, with models, and then you go to animal models. You're testing if the vaccine you developed is safe, but also effective. And if all this is going well, you go to the clinical phases, the phase 1, 2, and 3. But at the time you enter the clinical phase, the phase 1, you see that already a lot of drugs and vaccines development is stopped because there were side effects or it was not effective, and you have to restart. And that's what we call the preclinical phase, and that may already take 5, 10, or even a longer time. I already mentioned for HIV, at this time we do not have a potential vaccine that is effective enough. For dengue, for instance, a tropical exotic virus, we don't have an effective vaccine yet, and that's an old infection. So it may take a long time. Then we go to the phase 1. So that's a small group. We then look to safety, that are maybe 10, 20, 30 patients. We look if the vaccine is safe. If something happens there, development is stopped. So if phase 1 is going well, you go to phase 2, and then you look to safety, but also effectiveness. And you see that already a lot of drugs are from the list at that time. And in the end, we go to phase 3, and that are then large groups are vaccinated, and we get more information. So the average time for developing a vaccine is, well, 10 years was not that bad, because the average time is at least 10 to 15 years, but it may be much longer, and it will not be shorter if you talk about new vaccines. And that's again underlying that developing a vaccine is a good response, but it's not the first response that will help us, because it takes time. Well, maybe one last question, then we do a short coffee break. Can we predict the next pandemic? There's no good or wrong, but can someone tell me, now we have Corona, with what kind of infection or what infection specific should we count for the near future? Does someone dare to give an idea? There's no good or wrong again. Someone?
Maybe another zoonotic infection. I don't know which one, but.
Very good, I think so, yeah. That's very much on the list. So zoonotic infections. We are very much aware that the behavior, the way we live with our animals, domestic but also wild animals, is a risk. It has to do with behavior. Sure, that's very high on the list. Others?
Maybe some bacterial infections because of the antimicrobial resistance of.
Yeah, very good. Yeah, you already saw that it is on the list, the WHO list of the health threats. So antimicrobial resistance is one of them, and that really is a problem, as I said, also in the Western European countries. Of course, the airborne infections, we're counting with the possibility of an influenza pandemic. We see that every 45, 50 years. So these are indeed some examples. And this is a very, well, maybe it's a bit pessimistic, but this picture shows why it is interesting to work in the field of infectious diseases. Why is it hard to predict? Maybe it's undoable, but at the same time, we have to make predictions and we need to prepare. Well, that it is difficult has to do with, if we have the virus, then we talk about virulence, and virulence is the potency of the virus to cause disease, and also the potency to spread. And that may differ over time. Viruses mutate, and that may be that the potency to really infect people may differ, may change over time, and also the ability to cause disease, mild or serious disease, or even cause mortality. So that has something to do with the evolution of the virus. It has to do with the vector. The vector must be there if we talk about mosquito-borne infections or rodents, and the vector must be able to transmit the virus, the infection. Then the host factor, as we are, so we may have a different sensitivity to be infected and to develop disease. We know that there are large differences between populations with a different ethnic and genetic background. So we do see that infection can cause dramatic disease in one population and only mild in another. An example is, for instance, dengue fever, dengue hemorrhagic fever. That's a big problem in Southeast Asia. but we do see dengue in Africa, but we don't see hemorrhagic fever. So it seems that the African population is protected in one or another way due to their background, their genetic background. Environment, of course, is important. So the vector, the virus, and the host must find each other. So there must be an environment that enables them to meet each other. Climate is a factor. And then the lowest point, infection pressure. It might be that if we are confronted with several infections from the same group, that we have a kind of cross protection, that leads to immunity of the population. Is if a new infection is introduced, an infection from the same group, it might be that we do have cross protection, and that we will not get really sick or very sick from this infection. So that's a benefit. But to make it very complicated, then we go to the upper line, that is immune enhancement. And that's the opposite. It might be indeed that we have antibodies from a former infection that we're confronted with, that are not really enough to eliminate the new virus, but worse than that, they can lead to an enhanced immune response, and that makes us very, very sick. So that makes it complicated. Also in Corona, we have looked at that because we have seen a lot of Corona infections in the past because it's a common cold virus. Is there immune enhancement with the introduction of the new infection? And what does that mean if we are going to vaccinate? Because then you expose people to, of course, to the virus. There's an immune response. And do we have to count with immune enhancement? Well, what we found so far for Corona, immune enhancement does not take place. We are lucky with that, because otherwise also vaccination strategies could be harmful. But anyhow, the list and the interaction between all these factors, that's different for new infections. So for every infection, there's a different dynamic. Means that, well, the field of working in infectious diseases, making predictions, is a very dynamic one and very interesting. And it has to do with all these factors. I think it's good to, two slides and then we do the coffee break, because this has to do with it. Can we make the prediction? Well, this was in the Volkskrant, the newspaper, in January. So in China, it was the start of the outbreak. It was an epidemic at that time. And then in the newspaper of January 22, there was still Wuhan virus, as it was the name at that time. Het kon best steeds meevallen. So it was not seen that it was really a big threat. It could be, but the general idea was, well, and of course we all know that a few weeks later we were confronted with the impact. So not only cancellation of flights, but lectures, everything, an enormous economic impact. And it showed that even if the virus is there, it's hard to predict how it will develop. Well, I think this is a good time. I would suggest to have a short break, 5 minutes, and to restart at 10:10. Okay?
Oké, dankjewel Erik. Tijd voor koffie.
Ja, tijd voor koffie. Jan, als jij er nog bent, waar zit die chat? Die vind ik niet.
Ja, het ligt er een beetje aan of dat je de Zoom-app of dat je hem gebruikt vanuit je browser, waar die zit. Oké, maar dan heb je zeg maar die werkbalk waar share screen zit.
Ja.
En dan zit er ergens, je hebt participants denk ik, maar er zit ook ergens iets met 3 puntjes waar je op kan klikken.
Ja, ik zie hem. Ja, ik heb hem.
En dan moet je hem vinden daar. Ja? Ja?
Ja, oké, dank je.
Oké, hoi.
Even een kopje koffie.
Jo.
This picture, the pyramid, the pyramid. And for many infections, it's true that, well, most cases are mild or asymptomatic. We do have the severe cases, and then the cases that are admitted to the hospital, so the fatal cases. For the epidemiology, of course, as working as a clinician, we are focused on the cases that come to the clinic. So that is the upper part of the figure. But if you look in respect to epidemiology and the prevention of infection and containment of an epidemic, it's very important to know the severe and also the mild and asymptomatic cases to know how the infection is spread. And Corona showed us that very clearly. So this is a picture for many cases, and of course the basis of the pyramid may be a bit different, with more or less mild or asymptomatic cases. This is also nothing new. Due to the corona outbreak, the replication factor, what we do see is that the replication factor for all kinds of infections is very different. If you look to COVID-19, it's around 1 to 2, 3. The replication factor does say something of the virulence of the virus, so the potency of the virus to really infect the host, so and also being spread, but also to cause infection. So that's one part of the explaining the replication factor. The other one is behavior. If a virus is very potent to infect other people, and it can easily cause disease, but our behavior is in that way that the spread of the virus is prevented, then we also will have a low replication factor. And that is also what we see with COVID. It much has to do with our behavior, what the replication factor will be. We also see, for instance, for measles, you all know that we are vaccinated for that, and that's good because measles is a very infective infection. So the yellow dot is the patient, and one measles case can easily infect 16 to 18 other people, and so it's very, very infectious. This is also nothing new. Herd immunity, we use that during an outbreak like corona. It's about the number of people that are protected, and if enough people are protected, then if the virus is introduced, it cannot get grip on the group. And those people that did not see, that are still naive for this infection, are protected by the other people around. So we use that during outbreaks, and we use that also in our vaccination campaigns. So in the Rijksvaccinatie program, we know that we have more than 93% of the people infected. For instance, for measles, we know that those people that could not be infected or did not vaccinate themselves, not infected, but vaccinate them, they are protected because the virus will not get grip on them because they are protected by the other people around. And that's herd immunity. So we use that during outbreaks, but also in vaccination policy and strategies. Well, this I said before, it all starts with awareness. I cannot underline that enough. Scientific awareness, but also public awareness. Awareness also has to do with surveillance. When do we start surveillance? You can say, well, if there's a weak healthcare system, especially healthcare, primary healthcare, then often we see that the first response starts when the first patient is there. And then that's the second figure. You will see that there is a steep increase of the number of cases, a large outbreak. Well, the sooner you start, and that is passive surveillance, then you already know there are mosquitoes. You know that the birds are infected, so the virus is there. The example of West Nile virus, that's really early surveillance. That leads to an early warning. Now we can expect that we will see patients in the future. We can already predict and prepare. We did predict, we are preparing now. And we hope if we do see cases on a large scale, that our healthcare systems is ready to take care of those cases. Another thing is that we are using more and more is citizen science, and that's what you see here. So citizens are involved in collecting scientific data. And this is an example. This is a large program in the Netherlands. It's around mosquito-borne infections. And there's a large group of young students at secondary high schools. They're involved in a program. It's called the Fear Scanner program. And they are now introduced in citizen science. They, with a special app, they are going to collect data about mosquitoes, about breeding places, so about environment. And those data on a large scale all over the Netherlands must lead to a better insights or early surveillance of what's happening in the Netherlands. And that's what we mean with the term citizen science. You will certainly read about that, because citizen science is really a thing that will be used more and more in prevention of infectious disease. How epidemics start. Well, this is a picture how it goes with all kinds of zoonotic infections. We call it, it starts with the sylvatic cycle. So that's somewhere in the rainforest. There are wild animals, there's a virus. Viruses may be transmitted from animal to animal, but maybe there may be a vector, a mosquito. For those people living in small villages near to those wild animals, there may be a spring over from the virus to those small villages. And then we see small outbreaks in small villages. And well, that's very worrisome if those viruses, if there's a spillover to the urban, to the large cities, and then that's the start of the urban cycle, and then we are confronted with large outbreaks. So this is how it starts with zoonotic infection. So this, of course, again, has to do much how we live, how we behave, and how we are living with our animal. This one we have seen, the importance how we live. Well, this is a term that has also been introduced, One Health approach. I don't know if you heard before. It sounds as really something really new, but it is actually, it's common sense. If you want to work on solutions, you cannot only work as a clinical doctor. You can do, but that's not the complete picture. So you have to work with veterinarians, because we learned most infections are zoonotic. So it has to do with animal reservoirs. So we work with veterinarians, but it also has much to do with environments. So we have to work with specialists in that field, and also with the entomologist. And that's what's meant with the One Health approach. And as I said before, there's a large program now around mosquito-borne infections in the Netherlands, with all large institutions, but also the KNMI, so the Weather Report Service is in it, Wageningen, entomologists, people working with birds, the volunteers, the bird ringers, the vogelringers, who do surveillance among bird populations. All these people are working in this One Health approach program, focusing on mosquito-borne infections. Well, then some examples, and that brings us back to the news and to the patients. So there's a group of tick-borne infections. We all knew Q fever, the large outbreak, large outbreak also sorry, I'm mentioning Lyme's disease. It's a tick-borne infection. We do see an increase in the number of cases in the Netherlands. So there's a good surveillance systems in the Netherlands for ticks to see if they if the Lyme bacteria is present. Here we do see it's not one tick. There are different populations, tick populations. And in 2016, due to that surveillance system, a new virus was found. Well, it's not new, but for the Netherlands, it's new. And it is the tick encephalitis virus, tick-borne encephalitis. Well, is it new? For the Netherlands it is, but in the countries around the Netherlands it's very prevalent. I come back to that in the next slide. And shortly after the first patient was introduced, it was a general practitioner who had a patient with an encephalitis. He thought about tick-borne encephalitis and he diagnosed the first patient. Till now, it are only a few cases in the Netherlands. So it's also always a little bit hard to predict if the spread will go very fast or gradually. But if you do see a patient with encephalitis in the Netherlands, tick-borne encephalitis should be on the list. Well, this is very relevant because we do have a very good vaccine. This is one of the infections we do have a vaccine available. And this is to show that it is not a new infection. So we see that already in Germany, Middle European countries with a large spread to the Eastern Europe and Asia, tick-borne encephalitis is very common. And if you do live in Austria, the children are vaccinated for tick-borne encephalitis in het Rijksvaccinatieprogramma van Oostenrijk. So in Austria, children do get the vaccine. And also in German, especially in the forest areas, tick-borne is present. So the virus decided in one or the other way to come to the Netherlands. It happened this year. We were aware there was a surveillance system. You can argue why did it not happen 10 years before, or maybe 10 years later? Why now? Well, that's multifactorial. That will have to do with environment, climate, how we live, and so on. Again, if you look to diagnostics, if a patient has complaints, we can detect the virus with the PCR method. If the complaints already are there for a longer time, let's say 5-6 days, then PCR will be negative. So if you ask for a PCR, it will be negative. But if you're still thinking about tick-borne encephalitis, you go to serology. Okay, we make a step and 20 minutes to go, 20-25. This is a patient, a man. He went to Qatar and he went for travel for business, and he was with a group. And when he came back in the Netherlands, he developed fever and shortness of breath. And he went to the general practitioner. Well, you are the GP, the general practitioner. What do you think? Do you have an idea? Someone returning from Qatar, developing complaints, what could this be? Shortness of breath and fever. Any idea? Okay. I see a very good suggestion, MERS. Why do you call TB? Others? Okay, these are very good suggestions. For TB, it's more a chronic infection. It will take more time. So 2 weeks is very short because the incubation period is much longer. But MERS is a very good one. That makes that you are aware that MERS is circulating in Qatar, in the Middle East. So there are some questions you can ask. Well, one of the questions when he went for business, did you do something else? Well, he said, yes, I made a tour like this with my colleagues. There were no other colleagues falling ill at this time when he presented. And then we come to MERS. Well, the GP made a picture. The patient came to his office. There was shortness of breath, but he could tell his story, and there was fever. But when the picture was made in the hospital, the radiologist did see this picture, and that what we see is that both lungs are involved. There's a diffuse inflammation of both lungs, and this is a very serious picture. Both lungs are involved, and this typically could fit with a MERS infection. So it's always good to make your differential diagnosis to keep it broad. So it might be bacterial. He also bacterial infection. He also stayed in hospitals. So it may be a common bacteria like pneumococcal disease, but also Legionnaires' disease. So Legionella could be the case, especially when you stay in hospitals, in hotels. Viral, as mentioned. Yeast could also be, but that are not acute infections, so that's not realistic in this case. But this can be how you start your differential diagnosis. So viral MERS is well, very likely, And it does has impact because it's a very infectious disease, contagious. And these kind of patients, it's as soon as you think about a MERS infection, the patient should be isolated. Don't read this, but what this is the triage. It's not that everyone from Qatar coming back and developing fever is suspected for MERS, but if you do have fever with respiratory symptoms, if you made a trip like he did with the camels, if you stayed in a hospital or you met other people with similar symptoms, then there is a realistic suspicion for MERS, and a patient like this should immediately be isolated. So if the GP is thinking of a MERS infection, he should isolate already at in the GP's location. Well, GP was mentioned in 2012. There was a new corona infection. It's a corona infection. It was thought that this could be the next pandemic, and it didn't happen. We have seen cases and we have seen peaks, and that's what you see in the left picture. But what we also learned, there are around 2,500 cases now, around 800 mortality among 800, so 800 patients died, and 27 countries where the virus has been found. But there has not been a spread on a large scale, not a real pandemic, and that has to do with that the virus is not has not the capacity to very easily bind in our respiratory tract, and that makes it hard for the virus to be transmitted from one to the other person. So we were in good luck with this virus till now, because we also know that viruses may mutate, they may change over time, and if the MERS virus is changing and the ability changes, that it can very easily be admitted to our respiratory tract, it may easily develop disease and it may be spread on a large scale. So MERS still is on the list of potential pandemic. Well, at that time in 2012, we thought there's a new infection. A lot of people are going to the Middle East around the Hajj, and there was a fear that people would come back bringing the virus, and that could be spread also in the Netherlands on a large scale, causing an epidemic for the Netherlands. It did not happen due to factors that I mentioned just before. So these are the most recent numbers. So we are involved in working on a vaccine for MERS. Here you see the vaccine has been used on dromedaries. You see those animals who did not get the vaccine and are infected with the virus. These animals don't get really sick. They get a snot nose, so mild symptoms. You see that on the pictures below. And those animals that were infected were fully protected by the vaccine. And that this vaccine is now a very successful phase 1 trial has been finished, and we will start with the phase 2 trial the end of this year, the beginning of next year. So that's the vaccine development trial for MERS corona. And in the meantime, we are already confronted with the new coronavirus, the COVID-19. So you see how it goes. What do we know about COVID or coronavirus infections from the past? There are differences and similarities. So it's nothing new. Coronaviruses is among the well, let's say the common cold viruses. Corona is known as a very mild virus. If you come to the Erasmus Medical Center as a patient, and we ask for the virologist to do, we take a sample, then the virology department will give us results. There will be influenza, parainfluenza, coronavirus will be in it. If there's corona, we know that it probably are mild symptoms, and the chance to develop severe disease is very low. But that may change if a virus is, well, mutating. A totally new form may start to circulate. Why is it coronavirus? I think most of you know. The yellow proteins around the membrane of the virus. We call it the spike proteins. They are very important in developing or in developing vaccines because they are very immunogenic. And if you look under electron microscope on the right side, you see those spikes and they form a corona around the virus. That's why they are called coronavirus. So in 2002-3, we were confronted with the first coronavirus, a new variant that was that caused very severe disease. It was the SARS virus, the serious adult respiratory syndrome virus. It started like this. There was a conference in Hong Kong. People from all around the world were in that hotel. One person, he came from China, was infected with that virus in China, also participated in the conference. And after the conference, participants went home, and all around the world there were cases with an unknown respiratory picture, and they were all found to be based on the new coronavirus at that time, and it was called the SARS virus. The impact was enormous. This is what happened. SARS corona didn't get to be pandemic, so there's, that has to do with the abilities of the virus, but mainly the measurements that were taken. They were huge at that time. So airports were closed, large conferences were blocked, there was a lockdown, and that seemed to be very effective in stopping the spread of the SARS virus. So here we see all over we do have around 2,500 cases, a mortality of 100 cases. So we managed to reduce the impact of this virus, mainly due to the measurements that were taken at that time, the lockdown. And much what we did now with the lockdown for this new coronavirus was based on the experiences in 2002 and 3, how effective that can be. Well, we all know about the new coronavirus. There's much, discussion now about the antibodies. I want to briefly discuss some with you because they are in the news and there's a lot of discussion. We have talked about neutralizing antibodies. If you have neutralizing antibodies, the virus will be cleared. But if antibodies are not completely neutralizing, they may cause an enhanced immune response. That is immune enhancement. As I said before, we did not find that yet in corona. We are lucky with that because that would be very worrisome. Then also vaccination would be a risky thing. So there's a lot to do about the duration of protection, and that has to do with waning immunity. How long are antibodies present? Well, what we see now is that the antibodies, the IgG antibodies in people that were infected is around 3 months. After 3 months, we see waning immunity, so titers become very low and maybe and even undetectable. The question is if antibody titers are good markers for our immunity and also our on the long term. We know that's not true. Also with low antibody titers, if you are confronted with a new infection, our immune system does has a memory, and the memory is the most important one, and that has to do with your B cells and your T cells. We don't measure that on a routine basis, but those are the most important cells to define if we are protected on the long term. So that has to do with the memory, to do with the B and T cell function, especially the T cells. And that's what we call correlates of protection. We can look at antibodies. It tells us something, but it's not the complete story. If we want to hear the complete story, we have to look to T cell function. Is it useful to test for antibodies? Well, I think on a large scale, if you do it on a population base, it's useful because you can say so many people are infected. It will tell you something about herd immunity. it's not very useful on an individual base. Because if the antibodies are not there, it's not sure that the person is not protected. And in the other way, if you find them, we don't know how long they will be there and how long protection will, what will be the duration of protection. Of course, it has to do with herd immunity. If you look to immunization, as you all might know, there are a lot of vaccines in the development already in phase 2 and even phase 3. We must be careful because we have seen the picture. We can only be sure if the vaccine is registered. So even in the phase 3 clinical trials, something may happen that stops development of the vaccine. If there's something with safety or effectiveness. So that's an important thing. The other thing that we can do is, as long as there's no vaccination, is treat patients with antibodies. We have done that successfully in Ebola, and there's a compound ZMAP that can be very useful. We can also do that with corona, but the thing to be aware of, that antibodies are only helpful if you give them to a patient in a very early phase of infection, if the virus is still there. So most people that come to the hospital are in a later stage of infection, and it is too late to be effective with antibodies. So there's only a very limited use of antibodies that is useful to be protective. So for corona, still there is not a very specific treatment that we can say that's specific and this is very effective. There is an antiviral compound that we are supplying out to our patients. It's remdesivir, but it is not the ideal candidate. But it is what we have, and we have to do it with this. There are compounds under research, antivirals and also monoclonal antibodies. As I said before, and that's true for antivirals and also for monoclonal antibodies, they will be useful and successful in the early stages of infections. So at the start of replication, if you directly start with your antivirals or with your monoclonal antibodies, but be aware that most patients do come in the hospital at a later stage. So, and then it's too late also for your antivirals. Well, vaccine research and development, as I said, we are involved in the vaccine trial for MERS, and we will also be involved in one of the vaccine trials for the current corona, for the COVID-19, the SARS-CoV-2 virus. So that's very interesting, of course. But that means in the meantime, we have to rely on our supportive treatment. That's that people come into the hospital at the right time, not too late. And we take care of circulation. That has to do with organ function, to remain organ function, and saturation, so that there's a good oxygen supply. And that is supportive treatment, and that's very, very crucial. So if patients come early and you have a good supportive treatment, you can save already a lot of patients. Well, there's been some trials with dexamethasone in SARS-CoV-2 infection, and that seems to be very successful in the patients that are ill, more serious, oxygen dependent, and that's also part of the treatment we give. Antibiotics, we only give them if there is a chance that there is also an antibiotic or a bacterial infection. In SARS-CoV-2, we see that it's that there's only a very low rate of patients also have a bacterial infection, so secondary bacterial infections. So only in the severe cases, we only start with antibiotic treatment. Okay, these are the last pictures. In the beginning, we had the question about are there already patients infected with dengue infection, mosquito-borne infection in the Netherlands? The answer was no, but this was in the news last week. And that was the patient that returned, the traveler that returned. She traveled to France and she developed dengue infection. And this was the first case in the Netherlands, a traveler in Europe coming back with import dengue infection. Okay, due to time, I skipped this one. And I think we go to the, well, it's good because we talked about the hemorrhagic viruses. Many of them are mosquito-borne infections. And this is a figure that summarizes the known hemorrhagic viruses. So as I said before, you can classify viruses based on their transmission route. So the arboviruses, the mosquito-borne infections, you can classify them on a clinical picture. For instance, the hemorrhagic fevers. That's a very relevant one. And then mentioning that many of the hemorrhagic viral infections are mosquito-borne. What you see is that we do have the families, so large families, the genus, and then the virus itself. We do see, well, viruses like Ebola, Marburg, dengue, yellow fever, and we do see that certain viruses like dengue and yellow fever, they are grouped under the flaviviruses. That means that they have a structure that is similarities in their structure. That's important for diagnostics, also for vaccine development. And you see the transmission routes here. So this is a very relevant group, and realize that Ebola, well, it really made the news. There was enormous outbreak in 2014, but dengue is the most, is the virus that is spread over, well, many continents, and the most prevalent viral hemorrhagic fever worldwide. So this is the most important in times of spreading of the virus. Well, this is about dengue. You see the spread, and this already is a bit older picture because we see that the upper line starts to change to the Middle European countries already. So it spreads very easily by mosquitoes. Well, hundreds of millions people are infected. Some are asymptomatic, others with mild disease. A small group, but because so many people are infected, a small proportion is still a large number in absolute numbers are developing severe disease, and these are people with dengue shock syndrome and hemorrhagic manifestations. In that group, mortality is quite high. Mortality very much also depends in which states people are and patients are coming to the hospital. And this is very much simplified picture. So we see the picture differentiate from undifferentiated fever to dengue hemorrhagic fever and dengue shock syndrome. Still, there's not a good vaccine. There is one, but it does not give full protection. And there is an issue with immune enhancement. If you get that vaccine, you are infected, confronted with another dengue virus, it might cause immune enhancement. So it seems not to be a safe strategy with this vaccine. These are other hemorrhagic fevers, the Marburg, Lassa, and Ebola. Also zoonotic, Ebola transmitted by bats, directly by bats or via wild animal that were infected by bats. And that's the picture you see on the right. Well, the impact of Ebola in 2014 was enormous. From the past, we know there were small outbreaks in small villages, a high mortality around 90%, and the virus was not able to spread. But in 2014, we saw that the virus that was circulating caused milder disease, but still a mortality of 60%. And the symptoms were not directly that people were developing hemorrhagic fever, but they were, that's what you see here in the left part. They developed complaints like fever, sore throat, diarrhea. And the first thought was not on an hemorrhagic fever, but on maybe a virus causing diarrhea. So people were not isolated, and that was also the main reason that the virus could very easily spread over large areas and countries. Well, these are the final numbers. And this is an underestimation because these are the confirmed cases and registered 15,000 cases, 11,000 deaths. So the impact was enormous. Okay. Well, the last picture, I think in a kind of short, movie, we flew over the field of emerging infections. It's a very dynamic dynamic field. We discussed about that. We are confronted with different viruses. Viruses mutate and they change over time. We have to do with different environments, different populations, so host factors, different health systems with different surveillance systems, and different health economics. So it's a very dynamic field. But still, we need to prepare and make predictions. And that's my final statement. We can't predict, but we not only can prepare, and we need to prepare. And as we have discussed for the Netherlands, that was one of the questions. I think airborne infections can be there anytime, corona or influenza, they're on the list. And mosquito-borne infections, especially also for the Netherlands, seem to be very relevant for the near future. Public communication is very important. We have shown that and discussed that. We face that new infections can start everywhere, that the One Health approach is the one we need. If you want to get a grant now for research in infectious disease, you really have to mention that you are following the One Health approach to come to solutions. So public education, very important. And attention for vaccination, not only developing vaccination, but also making that people will take the vaccination. So the trust they have in vaccines. Also for a new vaccine for corona, the same issues count. Inform the people and work on awareness, but also acceptance of new vaccines. And with that slide, I want to close this lecture. Are there still questions? I think we have maybe 1 or 2 minutes.
Thank you, Erik.
I have a question. You said the vaccine development takes about 10 to 15 years normally, but what do you think about everyone saying, all the world leaders are saying that the corona vaccine will be done in about 1 or 2 years?
Yeah, that's a good question. On average, if you are confronted with a new virus, if you focus on viruses, then you start from the beginning. In the case of corona and airborne infections, there already has been done a lot of work for SARS-CoV-1, for MERS. There already has been, and then you start at the next level. So you already have information. There's already knowledge. There are already vaccines, and then you can save some time. But for new infections, well, it's very realistic to count for 10 years, 10, 15 years or more. But it depends also the speed for the first stages, the preclinical phase. And to be true for world leaders, assuming that the vaccine will be there and already being very definite, that's not realistic. And that's what we learned from the past. I mentioned some examples, HIV, but also for other infections, it is very hard. Also dengue, I mentioned. there's a real need for an effective and safe vaccine for dengue. It still is not there. And that shows that it may be very hard. Sometimes it's easy and often it's hard. Other questions? Okay.
I don't think so, Erik. Also, no questions in the chat. So.
Okay, then I give the word back to you, Jan, as the chairman.
Yes.
Mhm.
Thank you very much,
Okay.
Erik. And so we have a break and we continue with Paul Metten's lectures in 15 minutes. Okay, see you soon.